Diabetes was first recorded in ancient civilizations as a condition where people urinated excessively and felt very thirsty. Aretius of Cappadocia called it diabetes, which means to pass through, highlighting the frequent urination. In the 1600s, Thomas Willis discovered that the urine of diabetic patients was sweet, which led to the term mellitus, meaning honey sweet, to differentiate it from diabetes insipidus.
In the 1800s, research showed the pancreas was crucial for regulating blood sugar. Langerhans identified the pancreatic islets, and experiments by von Meringue and Minkowski confirmed that removing the pancreas caused diabetes in dogs. The discovery of insulin in the early 1920s turned diabetes from a fatal condition into a treatable one, initially focused on type 1 diabetes. Harold Hemsworth in 1936 distinguished insulin-sensitive versus insulin-insensitive diabetes, laying the foundation for what we now call type 2 diabetes. From the 1950s onward, scientists discovered insulin resistance and B-cell problems. Molecular studies of insulin receptors helped us understand why type 2 develops. Medications then evolved. Sulfonylureas stimulate insulin, metformin improves sensitivity, and modern therapies include GLP-1 receptor agonists and SGLT2 inhibitors. Today, type 2 diabetes is recognized as a complex disease influenced by genetics, lifestyle, and obesity. Increasingly, it's seen in younger populations, and treatments emphasize personalized approaches and preventing complications. Type 2 diabetes develops when the insulin-producing B cells in the pancreas progressively fail, usually after insulin resistance develops. This means the body's cells stop responding properly to insulin, causing blood sugar to rise. Insulin resistance and B cell dysfunction are the core problems driving the disease. Several biological mechanisms worsen type 2 diabetes. Dyslipidemia is abnormal fat metabolism that disrupts energy balance. Hyperglycemia is when consistently high blood sugar damages cells. Ectopic lipid deposition occurs when fat accumulates in organs that aren't designed to store it, like the liver and muscles. Endoplasmic reticulum stress, also known as ERS, and oxidative stress happens when cellular stress damages B cells. Inflammation occurs when chronic low-grade inflammation worsens insulin resistance. Type 2 diabetes is often part of a broader condition called metabolic dysfunction syndrome, also known as MDS, where multiple metabolic issues such as obesity, liver fat, and dyslipidemia exist together and amplify risk. Long-term metabolic disturbances cause target organ damage, including microvascular complications such as the eye, kidney, and nerve damage, and macrovascular complications such as heart attacks, strokes, and peripheral vascular disease. Essentially, type 2 diabetes doesn't just affect blood sugar, it triggers a cascade of metabolic problems that harm multiple organ systems. Research shows that people who feel lonely are more likely to develop type 2 diabetes. Loneliness here means feeling emotionally disconnected or lacking meaningful relationships. Social isolation, such as having fewer social contacts and not participating in group activities, also raises diabetes risk. This highlights that actual social interaction matters, not just feelings. When loneliness and isolation occur together, the risk goes up even further, suggesting that a combination of emotional and structural social deficits puts extra stress on the body and metabolism. These findings emphasize that type 2 diabetes risk isn't just about genetics, diet, or exercise. The social context and interpersonal connections play an important role in preventing or triggering the disease. Diabetes distress captures the emotional weight of living with diabetes, particularly managing daily routines and fears about long-term complications. Patients often experience guilt or anxiety if they feel they aren't managing their diabetes so-called well enough, and they may worry constantly about potential health consequences. The distress spans 6 key areas: treatment regimen, such as following medication schedules, injections, or lifestyle changes; food and eating, including managing diet restrictions and planning meals; future and complications, such as concerns about long-term health issues like cardiovascular disease or neuropathy; hypoglycemia, the fear of low blood sugar events; social and interpersonal relationships characterized by stress related to family, friends, or work life, and interactions with healthcare professionals, which is feeling misunderstood or frustrated with medical guidance. Importantly, diabetes distress is not rare. Over 20% of people with diabetes experience significant, ongoing psychological burden, making it a critical aspect of diabetes care. Healthy eating is a cornerstone of prevention. Choosing foods lower in fat and calories while emphasizing fiber, fruits, vegetables, and whole grains helps control blood sugar and weight. Physical activity is essential. Aim for at least 150 minutes per week of moderate or vigorous exercise, such as brisk walking, cycling, running, or swimming. It improves insulin sensitivity. Weight loss is particularly important for people with prediabetes. Losing just 7 to 10% of body weight can significantly reduce the risk of developing type 2 diabetes. Even small sustained weight reductions have a big impact. Avoid prolonged sitting. Being sedentary for long stretches raises risk, so standing up and moving for a few minutes every 30 minutes helps keep blood sugar and metabolism more stable. Metformin may be prescribed for some high-risk individuals, especially older adults who are obese and cannot achieve sufficient blood sugar control through lifestyle changes alone. It works to lower blood glucose and slow progression from prediabetes to type 2 diabetes. Lifestyle and self-management are the foundation of type 2 diabetes treatment. Managing weight, eating a balanced diet, staying physically active, and monitoring blood glucose, including HbA1c, are essential first steps before relying on medication. Oral medications are tailored to patient physiology and disease progression, such as biguanides like metformin improve insulin sensitivity. They're historically derived from plants like French lilac. Sulfonylureas stimulate the pancreas to produce more insulin if beta cells are functional. Thiazolidinediones, also known as TZDs, target insulin resistance directly. SGLT2 inhibitors lower blood glucose by preventing reabsorption in the kidneys. Incretin-based therapies are GLP-1 receptor agonists, DPP-4.